Hello, and welcome to today's webinar, Breast Cancer and Stress, the Role of Stress and How to Manage It. My name is Michelle Dixon, and I am the Program and Development Director for Massachusetts Breast Cancer Coalition, and I'd like to thank you all for joining us today. I am pleased to welcome our speaker, Dr. Jamie Jacobs. Dr. Jacobs is a psychologist at Massachusetts General Hospital Cancer Center and an assistant professor in the Department of Psychiatry at Harvard Medical School, where she teaches the Mind, Brain, Behavior Seminar course, Fighting Cancer with the Mind. Dr. Jacobs received her PhD from the University of Miami, Florida, specializing in health psychology and behavioral medicine. She is currently conducting a study funded by National Cancer Institute of the National Institutes of Health to develop an intervention to improve symptom management, distress, and adherence to endocrine therapy for breast cancer survivors. She is also a co-investigator on a study testing a psychosocial intervention for caregivers of patients undergoing stem cell transplant. Dr. Jacobs has received citation awards for excellence from the American Psycho-Oncology Society, the Society of Behavioral Medicine, and the American Psychosomatic Society. Dr. Jacobs, thank you for joining us and welcome.
Thank you so much, Michelle, for that introduction, and thank you to the Massachusetts Breast Cancer Coalition for inviting me to participate in this webinar series. As Michelle mentioned, my name is Jamie Jacobs. I'm a clinical psychologist and researcher at the Cancer Center at Mass General Hospital, and I'm excited to talk to you today about breast cancer and the role of stress. So it appears as though my slides aren't advancing. You can all just bear with me. Michelle, any ideas? Oh, there we go. Okay. So thanks for all bearing with me. In the context of breast cancer prevention, I'm going to take a bit of a different spin and explore how stress manifests when a person is diagnosed with cancer, and in this case, breast cancer, and the role that stress plays in adjustment to illness and treatment in many domains. So together, we'll discuss the benefits of stress management and the prevention of many conditions and comorbidities that can be exacerbated or worsened by stress. Specifically, we'll discuss the role for stress management in prevention of psychological disorders, generally elevated distress in the form of depression or anxiety symptoms after breast cancer, stress management and the prevention of how side effects or symptoms from treatment may interfere with one's ability to live life meaningfully and function on a daily basis, how managing stress may ensure one's ability to adhere to treatment or medication regimens that optimize treatment success and therapeutic efficacy of the cancer-fighting drugs we have, and finally, how stress management may confer benefit by reducing the likelihood of disease progression, recurrence of breast cancer, and ultimately may improve survival outcomes. So I want to take a moment to introduce you all to the field of psychosocial oncology. Some of you may be familiar with this. Psychosocial care refers to mental health clinicians and behavioral researchers with expertise in the diagnosis and treatment of emotional difficulties and psychiatric illnesses that can arise in the context of cancer treatment. So we think of psychosocial oncology as an interdisciplinary field at the intersection of physical, social, psychological, and behavioral aspects of the cancer experience for both patients and their caregivers, informal caregivers being relatives or friends of a loved one with cancer. And it's now recognized to be an integral part of quality cancer care, dealing with aspects of an individual beyond the medical treatment, including the psychological reactions to the experience of cancer, behavioral components of coping with cancer, and social factors, including communication with providers and loved ones. So my talk today will focus on stress and how the field of psychosocial oncology aims to conceptualize the role of stress in breast cancer and introduce you, hopefully, to some research being done at the intersection of stress, mental and physical health outcomes, and breast cancer. So to start, what is stress as we know it? Stress is, simply put, the body's reaction to a challenge you're presented with in a given moment. So our bodies activate the stress response in order to equip you with the tools necessary to manage a stressor. Acute stress is brief and is in response to situations where you can see the end in sight, some specified amount of time that you know you'll be stressed. In times of acute stress, the body's stress response is adaptive because it enhances our performance. It enables us to react in ways to meet the demands of a situation, to meet the deadline, or to motivate you to accomplish the task. So what actually happens in the body during those times of acute stress? Our bodies respond by activating the fight or flight response. This is a physiological reaction that helps you to respond to danger by fighting or fleeing, essentially. Our perception of danger or stress in the brain sends a signal to the rest of the body through the nervous system here to fight or to flee. The body responds by releasing stress hormones through our sympathetic nervous system, such as adrenaline, which many of you may be familiar with, the feeling that increases blood pressure, speeds heart rate, and raises blood sugar levels. These changes help a person act with greater strength and speed to combat the situation, to flee from danger, or to motivate. However, when a stressor is repeatedly experienced over time, or we're faced with a situation with no definite endpoint, our body responds by being in a constant state of fight or flight, called chronic stress. Acute stress can become chronic and creates a new state in your body of elevated stress chemicals, hormones, and these physiological reactions through the sympathetic nervous system that are now sustained at high levels rather than returning to a resting state, which we call homeostasis. This can be very taxing and can contribute to health problems. There's wear and tear on the body with this system constantly being elevated. Research has shown that people who experience intense and long-term chronic stress are more prone to viral infections, such as the flu or the common cold. They tend to have more headaches and sleep trouble, and even more long-term can experience issues such as digestive problems or fertility, urinary problems, and generally a weakened immune system. So in summary, we can think of stress as it is historically conceptualized in these three stages. First, with readying the body for fight or flight with the activation of adrenaline and other hormones and chemicals through the sympathetic nervous system, as I mentioned. Then followed in stage 2 by an eventual resistance or kind of an adaptation to the stressor as the sympathetic nervous system response declines. During this time, actually, cortisol, which some of you have heard of, a stress hormone, is continually secreted to maintain a more prolonged stress response. And finally, exhaustion sets in, which we all are familiar with. After intense, prolonged stress, we become tired, inactive, and vulnerable because the nervous system and immune systems no longer have the energy to sustain that heightened response. If a person in this stage doesn't find ways to manage stress levels, they're at risk of developing stress-related health conditions. Having no end in sight can really weaken the immune system and leave us prone to diseases such as cancer. In chronically stressful situations, such as being in treatment for breast cancer or living with a breast cancer diagnosis, the good news is that we can teach our bodies to dial down this fight or flight response so that it is not constantly elevated. Our goal is not to get rid of stress completely, as that is quite impossible, and also not adaptive. We want some stress is motivating, but rather our goal is to equip individuals that we work with skills to dial down the stress response, to gain more control of how stress interferes with the life that we want to lead. Now, an interesting question comes up after having a better understanding of those downstream effects of stress on physical health. Can stress cause breast cancer? There's an increasing and mounting evidence demonstrating the negative effects of stress on tumor growth, but the association between psychosocial stress and cancer risk is really less clear. A recent systematic review suggested a possible association, but was overall inconclusive, as many studies have been thus far. Although stress can cause a number of physical health problems, the evidence that it specifically causes cancer has been weak and inconsistent. Research that has suggested a relationship must really be explored further before we can actually say for certain that this link is there, because the apparent links between psychological stress and cancer could arise in several ways. For example, people under stress may develop certain behaviors such as smoking or overeating or drinking alcohol, which also increase a person's risk for cancer. And so it's hard to tease these apart. Now, given that information, there's really a different question to be asked. The evidence for whether stress causes breast cancer is weak, but do we know about the effects of stress for those who already have cancer? How do we understand stress in the context of breast cancer that is already diagnosed? Changes brought about by breast cancer diagnosis and treatment can include a whole host of issues listed here, like increased anxiety, depressed mood, disruptions in social life and relationships, fatigue, pain, and other symptoms that interfere with quality of life, change in sexual function or interest, long-term side effects, and sustained fears of recurrence and uncertainty about the future. In the case of breast cancer, a person is faced with both acute stress and chronic stress, and often the acute stress turns into chronic stress, and this can lead to something that we know of as distress. Whereas stress, as I explained it before, is an internal state, a response, or even an adaptive response. Distress is an aversive, negative state, an inability to cope with changes in the environment brought on by severe stress, which is prolonged. So let's talk about distress in breast cancer. The rate of people surviving after breast cancer is high, fortunately, and many individuals live long lives. However, they can continue to experience late onset side effects and long-term physical and emotional sequelae beginning at diagnosis, persisting through treatment, and lasting well into long-term survivorship. When people feel they're unable to manage or control the changes caused by cancer, the stress they feel can lead to the experience of distress. And distress has become increasingly recognized as a factor that can reduce the quality of life for people living with breast cancer. There is even some evidence that extreme distress is associated with poor disease outcomes like recurrence and mortality. As a result of psychological distress, people are more likely to experience depression, anxiety, or even a combination of both at very high rates shown here, with about 1/3 of women experiencing depressive symptoms during breast cancer. So let's return for a moment to our question about how stress affects people who have cancer. The short and simple answer is that stress can affect a tumor's ability to grow and spread. Also, we know this as metastasis. So let's explore actually how this happens within this model, which shows the downstream effects of stress on the body. As you can see here, we previously discussed how acute stress activates systems in our body that prepares the body for survival, and that chronic stress inhibits the turning off of these systems and can lead to wear and tear. In the case of cancer, being the stressful event here, leading to distress in the form of depression or anxiety in response to that perceived stress, the message that the brain receives triggers two systems in our bodies to respond. One system secretes cortisol, as I mentioned, the stress hormone. The other system, the sympathetic nervous system, releases adrenaline, noradrenaline, and other chemicals and hormones that gets our body ready for fight or flight. I had mentioned before that in the acute sense, these systems are protective. They allow us to respond to stress. However, chronic stress hormones can actually block processes that kill diseased cells and prevent them from spreading. Without the ability to kill these diseased cells, like cancer cells, and stop them from spreading, cancer is more likely to grow and spread. Studies in mice and in human cancer cells grown in the laboratory have found that the stress hormone adrenaline, part of the body's fight or flight response system, may promote cancer growth and metastasis. Chronic stress, as you can see here on the bottom, also leads to the production of certain growth factors that can increase your blood supply. These can speed the development of cancerous tumors, which are living off of the blood supply. Stress can also affect the immune system, making it less likely that immune components such as natural killer cells, showed here, natural killer function. So it decreases the natural killer cell ability to identify and attack foreign invaders such as cancer cells. And with cancer more likely to grow and spread under stress, we also see a deterioration in the quality of life of the person living with cancer. So now that we understand how these processes work in animal models and in human cancer cells in the laboratory, the question is, how does this manifest clinically? What do we see in real life? Well, over the past 2 decades, much research has focused on the connection between depression as a perceived stressor and survival in people diagnosed with cancer. We have found that the diagnosis of depression or just higher depressive symptoms is associated with higher mortality in cancer. The association is found when we measure depression before or after cancer diagnosis, and even after researchers controlled for the effect of other medical factors, such as the person having other diseases or what types of treatment they received for their cancer. As I showed previously, depressive symptoms are common, with about a third of women meeting some criteria for depressive symptoms during treatment for breast cancer. So I'm going to present to you now some previous work that I did at the University of Miami in Florida with Dr. Michael Antoni, a clinical psychologist and researcher as well. We explored the question of whether depressive symptoms were associated with mortality in a sample of 240 women with breast cancer. We found that the more depressive symptoms a woman reported, the higher, on average, the higher likelihood of mortality. This chart here that you can see is called a survival curve, where you can look at any point across this curve and see the proportion of people that are still alive. Each step along this curve signifies a point that someone passed away. You can see that the solid black line shown here are people with no depressive symptoms or mild depressive symptoms, with over 90% of these women being still alive here at this point in 2013, 11 years approximately after their diagnosis. However, the gray line shown here signifies women with moderate depressive symptoms or higher. Over 60% were alive after the 11 years in 2013. So in summary, women with less depressive symptoms were more likely to be alive later than those with higher depressive symptoms. In this analysis, we also took many other factors into account, such as the size of the tumor, the stage of the disease, the type of treatment they received, and actually how old they were. Although there were limitations to this study, several studies are being published now showing the link between depression and survival in cancer. Now, while it's possible that the downstream model I showed previously illustrating that stress response can explain the relationship between stress in the form of depression and mortality, it is also possible that many other factors can explain this relationship, such as the fact that people who are depressed are less likely to get treatment or more likely to engage in negative health behaviors such as drinking and smoking. They're less likely to eat healthy. And so these are important factors to consider when we want to establish the link between depression and mortality. So given some of this information, another question we tend to get is, what can we do about stress? Whether stress leads to distress, such as depression, we know that we do want to figure out a way to manage stress better. The goal is not entirely to eliminate stress, as some stress, as I mentioned, is good, motivating, necessary for our survival, as we illustrated before. But rather, our goal is to manage stress so it doesn't feel completely uncontrollable and overwhelming. If stress can increase adrenaline, cortisol in the body, then what can we do to dial this down and return to normal resting levels? In fact, we can teach our bodies to elicit the opposite response, or the relaxation response. The stress and relaxation response cannot coexist, so prompting a relaxation response will prevent or slow the release of hormones and result in a feeling that stress doesn't completely run your life. The goal is to gain controllability around stress. I'd like to take a moment for all of us to experience just how closely our minds and bodies are connected. So the term mind-body connection is popping up everywhere these days, but rarely do we really understand what is meant by that. So if you would take a moment wherever you are, maybe you're eating your lunch, just take a moment to stop what you're doing and engage in a very brief mind-body connection exercise with me. This will only take a few seconds. Get comfortable in your chair, gently close your eyes, and take a breath in and out. Imagine a ripe lemon on a clean white plate. Notice the bright yellow, waxy skin of the lemon. Hold the lemon to your nose and smell the fresh citrus scent. Now place it back down and slice the lemon with a knife, watching as the juice trickles out and the aroma becomes stronger. Now bring the lemon to your mouth and slowly bite into it, tasting the sourness of the citrus fruit, noticing the sharp tang on your tongue. Now place the lemon back down on the plate, letting the sourness linger on your taste buds. Take another moment to focus on your breath, and when you are ready, open your eyes. So as many of you may notice, perhaps you had the experience of puckering, your mouth puckering. Perhaps some of you had the experience of salivating, noticing some saliva gathering in the back of your throat. Or perhaps any other sensation of imagining that lemon was really strong for you. So this indicates how closely the mind and body are connected. There was no lemon present, but just the perception of a lemon triggered a physical response in your body. And in that same way, just the perception of stress can trigger a physical response in the body. So we want to do the opposite and trigger the perception of relaxation in order to shut off or dial down that stress response in the body. So how do we manage stress? There are multiple evidence-based treatments for mood and anxiety disorders in the general population that have been adapted to deal with stressors directly related to cancer. So we do this through programs that are designed to increase our ability to cope with stress and to practice relaxation exercises with breathing and meditative exercises. You may have noticed, even if you didn't have a sensation in response to the lemon imagery we just did, that you might have felt more relaxed by just taking a minute during your day to close your eyes and focus on your breath. So we want to give people the skills to be able to do this more often. We want to build these skills to manage stress, enhance social support with communication skills for interactions with providers and loved ones, and enhance our overall coping with whatever stressful thing we're encountering. We call these programs psychosocial interventions. It's a kind of fancy word, but it's basically a therapy program that's multimodal in that they incorporate many aspects of therapy and are based in therapies that have shown to be effective, as I mentioned, in different settings for depression, anxiety, or other issues of adjustment. And we study these interventions in the context of cancer. One particular one that I'll talk about today is a psychosocial therapy intervention or program called Cognitive Behavioral Stress Management, or known for short as CBSM. It was developed by Dr. Antoni and researchers at the University of Miami. And along with myself, we studied it specifically for women after surgery for breast cancer as they were going through treatment. Cognitive Behavioral Stress Management, or CBSM, is one of these multimodal therapies based in cognitive behavioral therapy, which is a gold standard evidence-based therapy for depression and anxiety and other conditions, and also combines aspects of relaxation training. So in addition to the components of CBT that are standard, the relaxation training includes a sampling of several techniques: progressive muscle relaxation, guided visual imagery, diaphragmatic breathing, and mindfulness meditation. I don't have time to go into much more detail about these, but I'll give you a little bit of an idea of what this entails. The therapy program, CBSM, was delivered by trained mental health professionals, such as a psychologist or psychology doctoral student. And the women in this program participated in 10 weeks of CBSM for 90 minutes each week in a group of 4 to 5 women. So briefly, as an example, during this session, the therapist would teach how we breathe with our diaphragms rather than shallow chest breathing. It's a more efficient way of breathing that gets more oxygen to our blood through the lungs and is one way to reduce distress. We teach how this is done, and then we practice it in the session, and then we assign practice exercise between sessions with audio recorded relaxation exercises that people received in CDs, or nowadays we're more likely to use MP3 files that we email to participants. Another component of CBT is called cognitive restructuring. So during breast cancer, individuals report being consumed with thoughts or worries about the future. And we try to notice what thoughts might be unhelpful or unrealistic or overly negative without good evidence to support it. We give people skills for how to replace their unhelpful thoughts with more accurate, realistic thoughts that are more flexible since the future is really unknown. This is very different, I want to point out, than encouraging people to think positively. Rather than telling people to think positively, we give people permission to acknowledge a range of emotions and feel okay with the negative emotions they're experiencing while making sure that the way they're thinking about something is truly accurate. Another component of stress management incorporates choosing a coping strategy based on how controllable a stressor is, expanding coping possibilities in different situations. So for things that are more controllable, taking action, and for things that are less controllable, managing our emotions. We also reduce the use of potentially damaging coping strategies, like engaging in risky or negative health behaviors, or avoidance or procrastination. The work we do aims to compare these psychological interventions for outcomes of psychological and physical well-being for women who receive the stress management intervention compared with those that don't receive it. And this work was funded by the National Cancer Institute. So between 1998 and 2005, women were recruited from private community oncology practices in South Florida and Sylvester Cancer Center at the University of Miami. 240 women with stage 0 to 3B breast cancer, non-metastatic, were enrolled 2 to 10 weeks post-surgery prior to adjuvant treatment, and they were randomized to either the stress management or the control group. Women randomized to the control group shown here participated in a one-day self-help type seminar within the 10 weeks that these women participated in cognitive behavioral stress management. The people in the control group received general information about breast cancer and health, but they weren't given the stress management skills that women received in the CBSM group. All participants in the study completed self-reports at what we call the baseline assessment, so prior to the intervention or the control seminar. They also completed the same self-reports about mood and quality of life and anxiety at 6 months after, which was after the intervention, 1 year later, 5 years later, and then finally we collected data on mood, quality of life, and mortality and recurrence at 11 years, an 11-year median follow-up in 2013. Our goal was to overall study the effect of cognitive behavioral stress management on many processes that I've spoken about so far today. So first, does a therapeutic intervention like CBSM, which has cognitive, behavioral, and interpersonal skills practiced through relaxation and other exercises, actually reduce distress? Does it actually improve mood? Does it reduce anxiety? Second, does an intervention like this in turn affect tumor growth as it does in the laboratory settings, such that people who receive CBSM have reduced stress, such as the cortisol response, immune function, and better inflammatory processes? And third, does this in turn affect tumor growth as it does in the laboratory setting, such that people who receive CBSM have lower mortality and less disease recurrence? So this model in itself suggests an approach for tracking changes in psychological adaptation, biobehavioral processes, and cancer and clinical outcomes following a psychosocial intervention that's designed to address these aspects. So we first wanted to examine the first step, whether cognitive behavioral stress management would affect psychological adjustment to stress, mood, and quality of life. I'm briefly reviewing our findings with you, which we've published, showing that women assigned to the cognitive behavioral stress management intervention during breast cancer treatment, compared to the control group who did not receive CBSM, reported less disruption in their social lives during breast cancer, less depressive symptoms, less cancer-specific anxiety, greater emotional well-being, and other positive mood and lifestyle changes up to 1 year later. When we conducted our 5-year follow-up survey, we showed that women who had received CBSM also continued to report less depressive symptoms at 5 years than the control group. In 2013, we conducted another follow-up survey, as I mentioned, which was a median of 11 years after diagnosis, and found that women in the CBSM group reported less depressive symptoms. So the light blue is the CBSM group, and their depressive symptoms are shown here on the y-axis. Less depressive symptoms were shown compared to the control group, and this was already including statistically other demographic and medical factors that may have influenced their mood state. We also looked at the effects of CBSM on quality of life. and found that women who were in the CBSM group, again shown here in light blue, reported better quality of life. So in this time, a higher score is better, a higher quality of life, than those in the control group, over and above the same medical and demographic factors that we included statistically in the model that might have influenced quality of life. So we've briefly answered the question of whether CBSM can positively influence mood, quality of life, and distress in breast cancer. And this has been shown in multiple other studies with similar interventions. To examine the next part of this model, did women who were randomized to the intervention have a change in their physiological stress response, in those downstream effects of the sympathetic nervous system and cortisol on inflammation and immune suppression? Just briefly, in addition to improved psychological adaptation, we found that women assigned to the CBSM group experienced immune and neuroendocrine benefits compared to the control group. Specifically, they exhibited lower afternoon cortisol, that stress hormone that I mentioned, that's a part of the stress response, greater expression of certain immune components, and lower expression of inflammatory and metastatic processes that can contribute to tumor growth when we compare this with the control group. And finally, we examined whether there was a downstream effect on mortality and disease recurrence, shown here, the final step in our model. I want to just mention before I show you these results that despite the evidence in favor of this biopsychosocial model that I presented, there is mixed evidence regarding whether or not survival and recurrence might be altered by these types of psychosocial interventions, such as CBSM. There have actually been several meta-analyses and systematic reviews with women, mostly with metastatic breast cancer, and suggested that there's really not enough rigorous research to stand behind the findings that have shown that psychological interventions can improve survival and lower disease recurrence. A more recent review was conducted in 2013 with some additional studies included, and they concluded that psychosocial interventions were effective in influencing survival in metastatic breast cancer, but only in the short term at 12-month follow-up. These mixed findings can be attributed to many factors, but consistently the intervention components are ranging, and mostly this work has been done in metastatic breast cancer, where the disease progression is already quite invasive and aggressive, and we decided to study this question in non-metastatic breast cancer. So at this 11-year follow-up in 2013, we collected self-report information about whether women had a breast cancer recurrence, and we confirmed this with medical chart reviews. And then we collected data on survival from the Florida Cancer Data System and national death registries. We examined differences in survival, or what we also call mortality risk, related to breast cancer, related to any cause, and what's called disease-free survival, which is the time that elapsed from diagnosis to a breast cancer recurrence. And we did this while also statistically controlling for other factors that we know would influence mortality and recurrence, like age and disease characteristics. First, we looked at differences in the overall mortality rate, which we call survival here. And this is another survival curve, with the purple being the CBSM group. We found that over and above the effects of these other variables like age and disease characteristics, the assignment to the CBSM group was associated with improved survival. So women who were in the CBSM group had a mortality risk that was 0.2 times that of the control group at any point in time along the curve, which is significant as seen by our p-value here, which is less than 0.05. So women in the CBSM group were less likely, had a reduced mortality risk than women in the control group. Next, we looked at differences in the mortality rate due specifically to breast cancer. And this was again done between women in the CBSM group and the control group. This finding was almost statistically significant, but not quite, and not strong enough for us to say that there was a relationship here. And then we examined differences in the rate of breast cancer recurrence between the CBSM and control group. While there was a tendency for the assignment to the CBSM group to be associated with longer time elapsing before recurrence happened, this also was not found to be statistically significant. We did a final analysis where we repeated each of these three analyses in a subsample of women who only had invasive disease. So we removed women who had had stage 0 from the analysis and only included women with the stage 1, 2, and 3. We found significant effects for both of these outcomes shown here, such that being in the CBSM group was related to longer breast cancer specific survival and more time before breast cancer recurrence, which again we call disease-free survival, how long one survives without the disease recurring. It's worth noting a few limitations when we're interpreting the findings of this study. First, that we were working within the confines of a small sample size, relatively speaking, and not many people are likely to die from breast cancer anymore, which can affect the statistics that we conduct. Participants also in this study may have been more motivated and more treatment seeking at the outset and therefore somewhat healthier overall. But despite these limitations, the study does have many strengths, including the sample composition. Most patients were from community practices and about a third self-identified as a racial or ethnic minority. So this lends itself to increased generalizability in an overall population. Before I wrap up, I want to mention theoretically, how do we explain these findings that I just showed? So there are multiple pathways by which a psychosocial intervention, like cognitive behavioral stress management, that aims to manage stress, can influence disease outcomes. It is possible that the short and long-term psychological improvements that women in the CBSM group experienced led to the effects on survival and recurrence through that biopsychosocial model that I proposed earlier, meaning that CBSM was somehow protective. It buffered the negative effects of the stress response by preventing negative changes in immune, neuroendocrine, and inflammatory processes that may result in cancer growth and spread. However, there are also several other explanations worth entertaining. Depression, as we know, is an established risk factor for non-adherence with medical treatment. People are more likely with depression to skip medications or discontinue treatment altogether. We know this to be true for women who are on endocrine therapies or hormonal therapies after breast cancer. That treatment non-adherence with these long-term regimens may explain the poor clinical outcomes in breast cancer for those who are distressed or depressed. Since we know that women in the CBSM group had less depressive symptoms and better quality of life, even at the 11-year follow-up, than those in the control group, it may be that those women who were in CBSM were less depressed, and this positively influenced their medication and treatment adherence, making it more likely for them to have better cancer outcomes. In addition, there are group social dynamics that go on. This CBSM intervention was delivered in a group setting, and this can influence women's participation in health behaviors that can increase or decrease cancer risk, such as alcohol consumption, tobacco use, physical activity, and diet. So the CBSM participants might have been more likely to increase engagement in health behaviors and decrease engagement in more risky behaviors. There is some prior work that has shown that women with the largest psychological improvements during CBSM also showed the greatest immune effects. So thus CBSM-related changes in mood and affect may play a role in altering those physiological responses, such as immune functioning, that might in turn affect disease progression and survival. In summary, we don't have good evidence that stress can lead to breast cancer, although we do know that stress negatively affects our physical health. What else do we know? We do know that stress can lead to distress in the context of breast cancer, and this can manifest as anxiety, depression, or other psychological conditions that makes it difficult to cope. We do know that there are therapies that exist that can help people cope through stress management and relaxation training that are based in the gold standard cognitive behavioral therapy and other evidence-based interventions such as mindfulness-based stress reduction and acceptance commitment therapy. These all can improve mood and quality of life. We do know from animal and human cell models that the negative effects of stress can impact downstream tumor processes that make cancer more likely to grow and to spread. And we do know that there is some evidence suggesting that engagement in such stress management interventions can result in buffering those negative effects of the stress response on immune function and other wear and tear on the body. We have some evidence, but not enough, that stress management can make disease progression less likely. As a take-home message, and in conjunction with the Massachusetts Breast Cancer Coalition Prevention Mission, it's worth taking a moment of your time to do a mindful check-in with yourself, exploring what health behaviors and self-care strategies am I engaging in that could increase or decrease my physical health in general. I only name a few here, including stress management or relaxation of your choice. Everyone has a different idea of what is self-soothing, and what works for one doesn't work for the other. Engaging in physical activity, wearing sunscreen, limiting alcohol consumption, following screening guidelines, avoiding tobacco use, maintaining a healthy diet, and minimizing exposure to environmental toxins. I'd like to thank and acknowledge the National Cancer Institute and the Network on Biobehavioral Pathways in Cancer for funding the study, and the PI, Michael Antoni, and my other colleagues and collaborators at the University of Miami, where I did my training before coming to Mass General Hospital. I really appreciate you all having me today on this webinar, and I'm happy to answer any questions that you have on the topic.
Terrific. Thank you, Dr. Jacobs. One question comes through regarding, since the discussion around breast cancer is increasingly more and more about cure and prevention than we say maybe heard a decade or more ago, have you noticed that there's any role that plays, that change in discussion plays in the people that you see that are dealing with the diagnosis, in the sense of perhaps being more hopeful? Does that affect the stress levels in any way, or has that been examined?
That's a great question. There is more of a focus on cure and prevention, and the survival rate for breast cancer is much better than it used to be. We have much more targeted treatments that are meant to really get at the receptors that are positive for the certain types of breast cancer cells that are growing in the body, like hormonal therapy or Herceptin. And so there is a more hopeful outlook. However, that is still balanced by the side effects from treatment that women undergo, the recovery from surgery of their choice, lumpectomy or mastectomy or whatever is indicated, radiation and chemotherapy if that is indicated. And so I often see women clinically after they've finished treatment, when there is this idea that I think people do get from society, from the media, from messages that they're getting from maybe family and friends, that they're now cured and that they can return their lives to normal. Yet very few people feel like themselves after treatment, whether surgery, chemo, radiation, or even just being on hormonal therapy, which causes a whole host of side effects similar to a menopausal state. So people are really dealing with long-term survivorship issues, not feeling like themselves, not having the same amount of energy, having to find different ways to engage in life, to get back to their careers, to get back to their family responsibilities, managing concerns around body image, self-esteem, changes in sexual function, dryness as a result of the hormonal therapy. That focus moving on to cure or prevention hasn't changed how people experience treatment and how people live with cancer. And actually overall, our conversations and research have really shifted to living with cancer, because even if cancer is in remission or cured for the time being, risk of recurrence is there, and this leads to tremendous uncertainty in how people live their lives, and something that we refer to, and my patients refer to, as scanxiety, the tremendous anxiety experienced anytime a scan comes up, whether yearly or every 6 months or for some 3 months, and a constant roller coaster of emotions, despite the fact that the overall outlook for breast cancer may be more hopeful than it used to be. I hope that answers your question.
Yes, and do you see a difference in how your patients are responding depending on age, younger versus older specifically, in terms of the stress level?
Yes, younger women are generally much more distressed than older women. So while in older populations, we do see that depression generally increases, risk for depression increases with age. For younger women, we see that depression or distress related to breast cancer is more prevalent, often because there may be of childbearing years, or maybe they have young kids, or just, young adult children. There tend to be more mid-career, and so the younger the diagnosis, the more distress we see.
Okay. And can you tell me, how does someone who is dealing with a diagnosis find the psychosocial support that you've discussed? How would they go about finding support services?
Yeah, so the first step would really be to talk to the oncologist or the treating physician to find out if there are any resources available in their community clinic or in the cancer center, if it's a larger cancer center like Dana-Farber or Mass General that they're being treated at. The gold standard, as I mentioned in the beginning, has really shifted more towards psychosocial care being an integral part of quality cancer care. And the NCI has designated several cancer centers around the country to be what's called comprehensive cancer centers, which means that in order to be designated as one of these, you have to offer psychosocial care as part of your services. And so the first step would be to find out where you're getting your treatment, if there are psychologists, psychiatrists, or social workers on staff that are trained and specialized in cancer. Then beyond that, there are always psychologists that are specialized in behavioral health or health psychology or behavioral medicine, whether it's cancer or other chronic illnesses that you can find out in the community by checking with your insurance company. Psychology Today is a website that we often refer people to find local providers. There are also many online self-help resources. The cognitive behavioral stress management intervention that I described to you in these studies is available online. I think you can probably find it on Amazon. It's written in sort of a self-help book way, so you can walk yourself through some of the skills that we do in cognitive behavioral stress management. So I think hopefully that gives a range of possibilities and suggestions.
It does, thank you. I've got one last question for you. Have you used or evaluated any natural health practices, homeopathics, vitamin therapies, biofeedback?
Great question. My work focuses mostly on psychological, or as I mentioned, psychosocial interventions. We like to think about integrative health in terms of complementary approaches. So alternative medicine has historically been thought of as medicine that is done instead of conventional treatment, and we really want to be very careful about this because these practices, diets, or vitamin regimens haven't been investigated in the context of randomized controlled trials, which are the gold standard for bringing something into mainstream medicine. However, complementary approaches are things like acupuncture or biofeedback that can be used in addition to standard treatments such as chemotherapy, surgery, radiation, other targeted therapies that can be very beneficial for someone in terms of their psychological health and their psychosocial well-being. I specifically have not researched those in particular, but there are several studies and a mounting body of literature, especially on acupuncture, that suggests that this can be helpful for symptom management. And often this is what I would recommend to patients, that those sorts of things like diet or biofeedback, acupuncture, and other holistic approaches can be very helpful for managing symptoms and side effects that come up during treatment, like pain, fatigue, nausea, and vomiting. Those are other non-pharmacological behavioral approaches that they can try. So I do recommend those generally, and if you're interested in more of the research, you can go on PubMed and see that there's much more research actually showing the effectiveness of acupuncture for pain and for nausea in the context of cancer, and hopefully we'll see more of this coming out in the coming days.
Great. Well, Dr. Jacobs, on behalf of Cheryl Osimo, NBCC's Executive Director, and our Board of Directors, I really want to thank you for taking the time to speak with us today and to share your research. And to our many listeners, I want to thank you for joining us. For those who are interested, the recording of this webinar will be made available later today on the NBCC website at www.nbcc.org. Dr. Jacobs, thank you again. And to everyone, have a good afternoon.
Thank you all. Bye.